Assalamu alaikum. Hope everyone is fine by the grace of Almighty Allah. Today we're going to talk about post-operative care in surgical patients. Post-op care comprises of three phases, thus immediate, intermediate, and convalescent phase. Immediate phase, also known as phase 1, thus post-anesthetic, thus in the recovery room. And intermediate phase started from discharge from the recovery room till the patient discharged from the hospital, comprises of whole hospital stay phase, that's phase 2. While convalescent phase is after discharge from the hospital till full recovery from the respiratory disease. What are the aims of phases 1 and 2? The main aims of these phases are maintaining homeostasis, treatment of pain, prevention and early detection and management of their complications. I will talk about immediate postoperative period. The dreadful complications that lead to morbidity and mortality postoperative period are either due to acute pulmonary problems, due to cardiovascular problems, or due to fluid derangements. How are we going to prevent it? The first phase, thus immediately after anesthesia while the patient is in the recovery room, there will be anesthetist responsibility toward cardiopulmonary functions and surgeon responsibility toward the operation site. Trained nursing staff should be there to handle postoperative instructions. Continuous monitoring of the patient should be done in immediate postoperative period, recording all the vital signs. Discharge from recovery room should be after complete stabilization of cardiovascular, pulmonary, and neurological functions, which usually takes 2 to 4 hours. And if patient didn't improve, then either he need to be shifted to high dependency unit or ICU care depending upon the facility in the respective hospital. What the postoperative orders? First thing is monitoring. It depends upon the type of anesthesia and type of surgery has been used. Like for minor surgery or even intermediate, vital sign recording would be as per norm, but for within anesthesia and particularly patient undergoing a major surgery, vital sign monitoring after every 15 to 30 minutes for first few hours, and then after improvement of the patient it could be just according to the patient condition. Patient might have CVP monitoring, patient might need continuous ECG monitoring, fluid balance should be checked, that would be intake and output record, particularly from the urinary catheter, and other type of monitoring that's specific to some patient like arterial pulses after vascular surgery and level of consciousness after neurosurgery. Postoperative care and orders regarding respiratory care again depends upon the type of anesthesia and type of surgery has been used. Patient might need oxygen mask only. Patient might need a ventilation if patient undergone thoracic surgery or major intra-abdominal surgery and need ICU monitoring with ventilation. Patient may need a tracheal section and chest physiotherapy as well. What to the position in the bed and mobilization? Postoperatively, again, it's depend upon the type of anesthesia and the surgery has the patient undergone. Like if patient have spinal anesthesia just for penile surgery or for inguinal hernia, or patient have moderate surgery like open cholecystectomy or laparoscopic cholecystectomy or any other intermediate abdominal surgery, after full recovery patient can be mobilized out of the bed. But for major surgery it would be given to the patient according to patient condition and its improvement. Some positions in the bed are particular to some specific surgery, like for thyroid surgery, we need to keep the patient in proper position that would be around 35 degree, almost sitting in the bed, so that the pressure in the upper part of the body would be reduced. Deep tissue prevention, either by some mechanical, that's intermittent cough compression, should be employed in high risk patient. What should be about the diet? Most of the patient we need to keep them NPO after undergoing some surgery for a couple of hours, and then we can start on oral liquid diet after full recovery from anesthesia, and then it can be proceed to soft diet or normal diet until unless there is some contraindication. Like if patient have undergone esophageal surgery or upper gastrointestinal tract surgery, particularly on stomach or small bowel loops, then it would be according to patient condition and surgical recommendation. Administration of IV foods depend upon the requirement and losses from gastrointestinal tract and urinary tract. If there is any stoma, then stoma loss and drain should also be included. The requirement also include insensible losses, and care should be given to patient with renal impairment while advising postoperative IV fluids. Postoperative medication like antibiotics, analgesia, and some patient may need some sedative agents. Care should be given to the patient who are on preoperative steroids. Anticoagulants can be given to the patient who are high risk or have vascular surgery. Antidiabetic and antihypertensive medication should be started at the earliest to control diabetes and hypertension. Certain lab tests and imaging investigation need to be done to detect or exclude postoperative complication. Now we'll talk about intermediate postoperative period that would start from complete recovery from anesthesia and last for the rest of the hospital stay. Care of the wound. Epithelialization of the wound took around 48 hours, so that dressing can be removed after 2 days after operation. But if the dressing is wet or there is significant swelling or patient have some complaint about it, then it can be changed even earlier to that. Symptoms and sign of infection should be looked for, which if present, then compression, removal of few stitches and daily dressing with swab for culture and sensitivity and starting antibiotics according to that should be done. Patient should have good nutrition in postoperative period to have good wound healing. How are we going to manage the drains? To drain certain fluid accumulation after surgery, particularly blood or pus, we need to keep the drain in. Either it would be open or closed system. Other type drain are like suction, some drain, or underwater seal that would be done in particularly thoracic surgery. Drain should be removed as long as they are not functioning or their purpose has been served. They should come out through a separate stab incision to minimize the risk of wound infection. Postoperatively, inspection of content and its amount should be monitored. Soft drain like Penrose drain should not be left for more than 40 days because they form a track and act as nidus and plug. Postoperative pulmonary care. Functional residual capacity and vital capacity decrease after major intra-abdominal surgery down to 40% of the postoperative or preoperative level. But they go up to 60 to 70% by 6 to 7 days and become normal afterwards in the postoperative period. Functional residual capacity, vital capacity, and postoperative pulmonary edema contribute to the changes in pulmonary function postoperatively. The above changes are accentuated by obesity, heavy smoking, or pre-existing lung disease, especially in elderly population. Postoperative atelectasis is enhanced by shallow breathing, pain, obesity, and abdominal distension, causing restriction of diaphragmatic movement. Postoperative physiotherapy, especially deep inspiration, help to decrease atelectasis, and also oxygen mask and periodic hyperinflation by using spirometer is helpful. Early mobilization helps a lot as well in postoperative period. Antibiotics and treatment of heart failure postoperatively by adequate management of fluid will help to reduce pulmonary edema. Respiratory failure in a postoperative period, either it would be early, that would be just 1 to 2 hours postoperatively, there's no definite cause, and it occurs suddenly, while late, that would be after 48 hours postoperatively, and it could be because of pulmonary embolism, abdominal distension, or due to opioid overdose. Patient would have tachypnea, that would be respiratory rate more than 25 to 30 per minute, low total volume, that would be less than 4 ml per kg, and on ABG there would be PCO2 would be more than 45 millimeter mercury, and partial pressure of oxygen would be less than 60 millimeter mercury. If the patient have these parameters, then he need to be immediately intubated and put on mechanical ventilation. Treatment of atelectasis, pneumonia, or pneumothorax, if any of these is there. How are we going to prevent it? Physiotherapy postoperatively, and even particularly advising preoperatively to prevent atelectasis. Treatment of any pre-existing pulmonary disease. Well hydration of the patient to avoid hypovolemia and later on atelectasis and infection. Patient may need hyperventilation to compensate for insufficiency of lung. Use of epidural block or local analgesia in patient with COPD to relieve pain and promotes effective respiratory muscles functions would be helpful. Now we'll talk about postoperative fluid and electrolyte management. Consideration should be given to maintenance requirement. Extra need resulting from systemic factors like fever, burn, diarrhea, and vomiting. Losses from the fistulae and the drains, and if there is any third space loss. The daily maintenance requirement in adult for sensible and insensible losses are around 1.5 liters to 2.5 liters per day, depending upon age, sex, weight, and body surface area. Rough estimate is around 1.8 liter to 2.4 liter per day. Requirement is increased with fever, hyperventilation, and increased catabolic state. Daily estimation of electrolyte is not necessary for every patient. It would be done in critical patients only. Potassium should not be added to IV fluid postoperatively within first 24 hours, but later on it can be added according to the daily requirement. The patient is kept NP for a prolonged period of time. Other electrolytes are corrected according to deficit. Postoperative period, Ringer lactate solution or 5% dextrose in normal saline is suitable for most of the patient. Daily requirement of IV fluid would be around 2 liter to 2.5 liter per day. So now we're going to talk about postoperative care of gastrointestinal tract. First thing is nothing paroral. That would be till the patient have fully recovered from anesthesia or the patient have certain restriction or contraindication to oral feeding, then you need to be kept NPO. Postoperative palliative care is usually resolved within 24 hours. So ideally patient could be started as early as possible postoperatively when is fully recovered from anesthesia. Nasogastric tube is not necessary after is only necessary after esophageal and gastric surgery, while it's not necessary after cholecystectomy, pelvic operation, or chronic dissections, gastrostomy and jejunostomy tubes. Feeding can start on second postoperative day because absorption from small bowel is not affected by laparotomy. Enteral feeding is better than parenteral feeding. Gradual return of oral feeding from liquid to normal diet should be encouraged. Now we'll talk about postoperative pain. That's one of the important factors in postoperative period. What are the factors affecting severity of pain depend upon the duration of surgery, degree of operative trauma like intrathoracic, intra-abdominal, or patient have just superficial surgery, type of incision play a vital role like in thoracic surgery or in upper abdominal surgery where the incision are used in subcostal region, patient would have more pain, and due to pain he would have restricted respiratory muscle movement, leading to atelectasis, pneumonia, and respiratory failure. Other factors including magnitude of intraoperative retraction and factors related to the patient are anxiety, fear, physical and cultural characteristics as well. What about the complication of pain? Due to pain, there will be vasospasm and hypertension, may cause CVA, myocardial infarction, or bleeding. And due to pain, patient is not taking deep breath, particularly when the incision are used in the upper abdomen, leading to poor respiratory efforts, leading to atelectasis, accentuated with pneumonia, and later on it can, particularly in elderly population, going to respiratory failure. And patient with major abdominal surgery, if it's not mobilized, it can have chances of getting DVT, prolonging of paralytic ileus, causing abdominal distension, and leading to nausea and vomiting, leading to fluid loss and electrolyte derangement, making the condition worse. So, control of pain is very important in postoperative period. Management of postoperative pain is first thing is reassurance, then with by some medication that would started in a stepladder fashion, that non-steroid like paracetamol, then steroid, and in severe pain parenteral opioids can be used. Patient might need some anxiolytic agents. Oral analgesics or rectal suppositories can be given in select population. Epidural analgesia is a very good choice for pelvic surgery, and even a patient controlled anesthesia is the best option in postoperative period. Nerve block, particularly post-thoracotomy or post-hernia repair, is one of the best way to control pain. These were the salient features and points needing attention in postoperative care in surgical patients. Hope is going to add on something to your knowledge. So if you have any question, you can ask in the comment section below. Otherwise, thank you very much for your attention. Have a good day.